Baltimore, 11 p.m. on a Tuesday. A 33-year-old guy, IT administrator, been wearing his Apple Watch 24/7, even to sleep, gets a notification. Irregular rhythm. He feels something off in his chest, he waits, hopes it resets. 6 a.m., still there. He goes to the ER. The doctors hook him up, confirm it immediately. Atrial fibrillation. Doctors could see when his heart went wrong because he wore a watch to sleep and the timestamp was in the data. They knew and acted. This story happened this year in a clinical trial, not in a clinical trial or press release, on a Tuesday night in someone's bedroom because a consumer device running an AI algorithm was paying attention when no human could. So Michael, this is where we're starting today, not with founding numbers, market projections, with a watch and a heartbeat. And what do you feel, how do you feel about this story?
I feel it's wonderful, really.
Okay.
First of all, a lifeless saint.
It's beautiful, yeah.
It's beautiful. The upside is clear. The second thing about it that amazes me is actually what goes under the hood. Mm-hmm. It's a fairly simple mechanism that laser probe our blood, and then they get the results via the algorithms. They then get results about the pressure, tempo, rhythm, and also even oxidation, which is crazy when you think about this.
Absolutely.
And everyone can have it. It's available for almost everyone. It's a consumer product, in this matter. So that's wonderful. And then you have this algorithmic layer on top of that, which was activated when nobody was looking.
Yeah. So we have like a sensor or the hardware layer, and then we have the second layer, which is kind of the digital thing, and we'll explain what that digital thing is. But before we do that, I have one statistic for you, the first one from many today. The Apple Heart study enrolled over 419,000 participants. Of those who received an irregular pulse notification, 84% had it confirmed as atrial fibrillation on follow-up ECG monitoring. Crazy number.
Crazy number.
And it's for 2019, so 7 years old.
Yeah. And we can expect these numbers to grow and similar studies to emerge because, as you mentioned, and the hardware, it's an excellent enabler. Mm-hmm. It helps us with the data extraction. And then as the more data we have, the more results we can emerge from the data.
So we don't have to change the hardware, right? Because
because then with the hardware widely available, people can extract data about themselves, and then we can fuel the great pools of data. For example, how we have these clinical trials. And then with the larger amounts of data, it's easier to spot the connections and create the pathways. Then having this compounding effect of creating these pathways more optimized and being available to be run on smaller and smaller hardware.
Very interesting. And we can even use the older hardware and use this AI to mitigate the oldness of the hardware, right?
Yeah, because sometimes it turns out that creating a very optimized pathway is more effective than having a priori written or written beforehand set of instructions that are deterministic.
So we touched the surface of AI, machine learning, LLM models, and this digital something thing. So I want to talk to you about that. And I sat in a lot of product meetings with founders, with scientists, with people who wanted to build some kind of the health tech product. Sometimes they say we're adding AI. And to be honest, I generally don't know if they're talking about ChatGPT, machine learning, LLM models, because the definition or their perception of the definition is very different. So maybe we can start from this very fundamental knowledge. What is the difference between AI, machine learning, LLM models? They're the same, they're old, they're new. This is something that is on the market for a couple of years, maybe decades. Like, can you explain that to us?
Sure. And that's actually my favorite part.
Okay.
I also don't know what they mean by this, because AI became sort of a catch-all term for many different domains and many different techniques. I mentioned domains and techniques.
But the good part is that they have us.
Yeah, that's why we're here. to help navigate in this complex ecosystem of domains and methods. And machine learning is mostly a method. You can apply it to pictures, you can apply it to language, hence the large language models. You can apply it to all kinds of signals you can have, be it heart rate, be it sound. You can use it almost everywhere. It's just a very sophisticated statistical method of analyzing data. So that's one thing. And under AI, we can first split it into domains. Mostly for practical reasons, we split it into computer vision, so giving the computer's ability to spot objects spatially. Then we have natural language processing, so understanding the language, extracting information from language, manipulating language. So all the stuff that became our daily bread with all the LLMs and Anthropic models, OpenAI models, everything that we use on a daily basis. Then also you have predictive analysis or classical, let's say, mathematical understanding of signals, where you can use machine learning to extrapolate existing sets of data to get some idea of what will happen. So you increase your probability of an informed guess, basically.
If you can explain in like one sentence or define the machine learning and LLM, if you can compare it to the role in the organization or in the like who's LLM and who's machine learning?
That's a great question. I'll probably stray away in a little bit to make it also a little bit easier for me, but I'll say that machine learning is employed everywhere when you have this decision making or augmenting the decisions. So when you need someone to be informed in a better way, you adjust machine learning algorithms to the signals, so you can either predict or detect anomalies or have similar behaviors to that. And then you have LLMs that are able to ingest a lot of data with different formats. They act as a bridge between structured and unstructured data, because we can also think of language as sort of unstructured data. But then again, it's more available to us humans. So having this said, the roles in the organizations, machine learning would be really the analysts, right? They give the insights, they create the reports, and then there's the spokesperson who actually reports all of that to the board, to anyone who's concerned.
Okay. So I want to move to this market research part. One fact, in 2024, 50% of all health tech AI investment went into administrative applications like documentation, scheduling, billing, versus only 37% into clinical applications. That's LLMs doing paperwork, not ML saving lives. This came from Silicon Valley Bank, Future of Health Tech Report 2024. What do you think about this difference?
That's really interesting, because at first glance it might sound a little bit counterintuitive, right? Saving lives is more important. But then again, saving time and effort on administrative work is more available. So again, it might have some justification in the fact that the investments are going into cost optimization rather than very far and ROI heavy endeavors, right? And there is some good in that, in a way that eliminating administrative and operational friction with doctors, with the professional staff, makes them more able to focus on the hard part, on the diagnostics, on the contact with the patients.
And the documentation is like the interesting part, because physicians spend more than half their workday documenting in electronic health records what they did and what they plan to do, and to describe the reality, right? And I have this interesting statistic, and it says a lot about AI, how it can help people. It's in a multi-center study across 6 US health systems with 263 physicians. Burnout dropped from 51.9% to 38.8% after just 30 days of using an AI documentation scribe, representing 74% lower odds of experiencing burnout. So it's super interesting for me because we are not talking about AI replacing humans, specialists, engineers, whatever, but we are talking about AI helping people to do their job better and to focus on the patient and to feel better from this mental perspective.
Yeah, here I could not concur more because here at Monterail we're coders. Nobody likes, and we know better than many people that writing documentation is pain.
Yeah.
But we also know that not having a documentation is a bigger pain, but it hits you later on.
Yep.
So again, here I know this is a stretch, but I completely understand this, and I feel like this is a great direction to actually limit this operational friction, to limit all this repetitive work as well. And again, protecting the mental ability and mental health state of the professional staff, because this is really what matters in the long run. Them working in more comfort will translate into better diagnostics. So again.
So we have this medical triad in the United, like everywhere, which is a patient per provider. And so we can easily say that this low-hanging fruit, that is some kind of the optimization of the P&L and the spreadsheet, right? Because we are talking basically of spreadsheet, saves a lot of time for clinicians, which the outcome is also like saving lives because they can be more focused. They can, as you said, focus on the diagnostic and what really matters. And there we can move when we somehow find this Pareto, feel 80%, we can focus on things or solutions that are really saving lives. So probably this balance will a little bit change, right?
Yeah.
Well, investments, I mean.
It's a great point, especially in the context of artificial intelligence, because in the context of AI, we often speak about alignment.
Yeah.
And here, what you mentioned is basically the alignment between the economic incentive and the rationale that's in the material world. So I'm 100% for this direction. And again, I hope that this will translate into more and more solutions being adopted to create this effect of having closer relationship between diagnostics and patients, while also making many services more available. Because again, what we can think of is the Jevons paradox, that if some diagnostics cost will become lower and lower, we can expect that they will become more available, and then the rate of public health being able to it will be able to improve with time, because the sieve will become more dense.
Yeah. So Michael, do you know what 12 minutes stands for?
Not really.
In case of healthcare system, this is the number of minutes that average physician they can spend on a patient.
That's wild.
Yeah, that's wild. 12 minutes. So when we talk about this optimization, this is more minutes to focus on the patient, as we said, and it's more saved lives, as we said, and this is like the huge system change and the saving. And maybe for us as a Europeans, it's a little bit different because we think about the healthcare system as a public service, not as a private company running the business to optimize the P&L. But in this case, we are shareholders of this healthcare system in Europe. So we should be aware of that problem of optimization. So now we're moving into the part of health tech that really excites me. We will talk about remote patient monitoring, and I've spent 15 years watching health products being built. Remote patient monitoring has been around for a while. For me, as I said, it's 15 years, but there's a before and after with AI. And before is you collect data and send it to a clinician who reviews this data. And after is the system is continuously looking for the signal that matters before anyone knows the look. And this is amazing because we are not talking about snapshots, but we are talking about trends.
Right. And this is a wonderful outlook on all of this, because again, with the hardware being the enabler, it's becoming more popular. So the amount of data that we have for training is bigger, but then again, the usefulness of this becomes greater. So with the bigger pools of data, we can have more diverse and more representative data sets, which statistically is important, because then again, we can use it as a fuel to get more meaningful predictions. Again, strengthening the case of being useful.
So what's the fundamental change here?
I feel like first of all is the confidence for building with AI and with accepting this either non-deterministic nature of the models, or also making this making it more available and getting used to having all of these systems near you.
So we're also talking about moving from periodic retroactive care or healthcare into more continuous proactive healthcare that supports doctors, patients, providers and payers, so the triad. And this is amazing change, right?
Sounds like everybody wins.
Yeah.
Because we are used to having this remote patient monitoring as a stream of data only. Right now we can expect something to come back as guides, as information, as processed data already. So as in the story that you mentioned, right? The user was informed, not the doctor or medical staff was informed that something is wrong, and it enabled someone to act accordingly.
And especially when someone leaves the hospital, the US Mass Memorial Health AI powered remote patient monitoring program for congestive heart failure reduced 30-day hospital readmission by 50%. It's a huge number, 50%.
And it makes a great case for the payers as well, right?
Yeah.
And it's very important for hospitals in this case.
Yeah. Especially that they increase their chances for reimbursement. And the big numbers here are remote patient maybe another way. The AI in the remote patient monitoring market was valued at $2 billion in 2024 and is projected to reach $13 billion by 2032, growing at 27% per year.
That sounds really impressive.
Yeah.
At first, and I believe it might grow either steadily or even more, because knowing what we know now is that the plateau of this ability is nowhere in sight, because again we have this compounding effect. More data means it's more useful, more usefulness forces people or pushes people towards denser networks of devices, of the data exchange, and then the pool is bigger, more diverse, and also statistically more significant, which again enables us to make it more useful. So we really don't know when this snowball effect will really stop and plateau at some point, and then maybe these investments will just stop growing.
Yeah. And you have $11 billion dollars difference between 2024 and 2032. So I'm wondering what's the saving for the healthcare system if we have this 11 billion. So how much more it will save because we use AI. But probably this is something we're gonna witness by our own in the future. So the question now is, what does it actually take to build a model that's trustworthy enough to act on in a clinical setting?
Here, definitely, we need to scope this into appropriate sections, because to answer it on a broader scale, if you want to have any model, you need to have environment. Any kind of model, you need a data set. And this data set cannot be any data set. The data has to be of certain quality, of certain integrity, and also out of this data, you have to be able to create hypotheses. You have to be able to validate these hypotheses. You have to be able to check them with the actual clinical subjects. So there's a lot of preparation work on this, and this is something that is mostly done on the intersection of academia, tech, and professionals, because professionals know where the pain points are. Academics can support the know-how, and the techies can actually make it happen.
And I'm really glad that we are touching that topic, especially that what keeps me up at night as someone who's shipped health products in the last 15 years, I found a study that reviewed over 1,000 FDA-approved AI medical devices. And it's interesting because the average transparency score, how well they reported what the model was, what data it was trained on, and how it actually performs, was 3.3 out of 17. Nearly half didn't even include a clinical study. We're deploying these settings in clinical. So we're deploying these things in clinical settings, and if something goes wrong, and this is like, I think the most crucial question, who's responsible? The hospital, the software company, the doctor who trusted the alert? I don't think anyone knows the answer yet.
Yes, and I feel like yet is really the most important keyword here.
You're more optimistic than...
Only a little bit.
Yeah, okay.
And it stems from not only from sheer optimism or belief in the technology itself. It's just that I really believe that we will know who is liable after after we have some kind of cases, after we have some precedents. We still lack precedents for that. There are efforts towards explainability or mechanistic interpretability of the models being one way of explaining how they work, what they do. And again, I feel like in this particular case about switching the liability, we'll know with time, because again, we're in a very early experimental stage. And again, for a solution to be explained, it's a lot of rework. It's easier to create it than to explain how it works. So again, I believe like this flow would be that there's a solution, it is created, then it has become more and more useful, and this creates a case to explain it. So we can reverse engineer our way into the network and to understand how does it really work.
Okay. I get it, but I think this is not something you can solve today, right? And this is not, we don't have answer yet. And until that's settled, I think the most responsible founders are the ones building in more human oversight than they think they need, not less, right? They need to add a little bit more human supervisory than less to be able to mitigate this also legal risk.
That's a proper touch on the topic. Human in the loop or human-centric design is really important in this, especially since we're still not in the clear about making decisions, currently approaching it more from the augmentative side. So having this processes that are enhanced by the information given by the models, given by any sort of AI or any other type of solution, makes a bigger case to again to be used and then to prove its reason to be explained later. So there is still a little tension in me because I feel like we can expect more and more products to be shipped without it and to be tested without it, because again, its accuracy sometimes justifies the uncertainty. I really agree with you that we need to be very wary and maybe even err on the side of caution with this one.
It reminded me my favorite quote from JFK about the moon. We choose to go to the moon not because it's easy, but because it's hard. And I think it's exactly the same with AI. It's hard to define all of the use cases. It's hard to find the final answer, but that's the destination, right? This is we are at the in between two points on a map, and we need to find the right path to get to the destination.
You really hit the nail on the head with this one, especially because, as I previously said, right now we can see some trajectory, but again we don't see the scale of this trajectory. Right now it looks like it's growing, but we don't know where the plateau point is. So again, we'll need to figure it out.
Yeah, like even Elon recently said that they're changing the Mars destination to the Moon destination because it's easier and achievable. So we started with Imani and his Apple Watch at the beginning, and I think that story captures exactly where we are in the market. a $400 consumer device running an algorithm trained on millions of heart readings so far costs something that would have been invisible until it wasn't. It was too late. That's not hype, that's happening. And at the same time, we are deploying AI in clinical settings where the transparency bar is 3.3 out of 17. Both things are true.
Yeah, and they're true at the same time, which is sort of paradoxical here. But again, we can expect that these situations will become more often, because again, not every solution is really life dependent, or maybe the other way around. Not every solution makes life dependent on it, right? Some of these are only advisory. And case of Imani is a great example, because if it would be a false negative, or for a false positive, so nothing bad would really be happening, then again, nothing bad would happen, right? But again, it makes the better case that we're actually saving lives with the positive reading of the alarm, rather than the other way around, not to catch it, right? And again, right now we are not able to predict in which cases and in which spheres of life solutions like this will become available and also widely adopted. There's some uncertainty about that, and definitely I feel like with the right collaboration between the private and the public sector, between academia and the tech network, between patients and diagnosers, I feel like we can expect this trend to become more and more prevalent.
And I will come back to the moon story, because I love that story, and I think the first moon landing was possible only when the entire industries, in plural, came together to work on that purpose, on that goal, right? And private sector, public sector, companies, like people with engineers and other industries, they were gathering together to work on that purpose. And here is exactly the same. We need to combine many different skill sets and many different roles and companies, industries to work on that goal. And I have one statistic, the final one. It's from Microsoft. I hope this statistic is a little bit better than their recent Microsoft updates that killed a lot of computers in the last couple of weeks. But in 2024, AI ventures captured 58% of all digital health funding globally, 14.1 billion out of 25.1 billion total. And here's the interesting part. And according to Microsoft EDC study, every $1 invested in healthcare AI generates $3.2 return within 14 months. Huge.
Wow, that sounds so
From
good.
$1 to 3.2.
Yeah, that sounds so good. I would really investigate how
it was AI generated.
How is it really measured? That beats the market, honestly. That's a good investment. However, in this scenario, I feel like starting from what investment basically is, we can expect that this is a perfectly rational move, given the information that is publicly available about the demographics, about the society is growing older. Anything that's related to healthcare and health tech will be probably most likely a good investment. And many of them will obviously fail and not suit the market, but some of them will, and they might win big. Because again, we can see all these trends about people living longer and also birth rates declining worldwide. So this creates this case of either remote patient monitoring or providing care remotely or minimizing the touch points only greater.
Yeah, and this is where I put my bets on healthcare and health tech, because I believe it will be a huge thing, and we need to, because of the silver tsunami that is coming, we need to invest a lot in health tech to make it more accessible, to make it more effective, and to spend that money wisely. So here's the question I want to leave you with. And honestly, Michael and I don't agree on the answer. Is AI in health tech moving at the right speed? I think we have a little bit different perspective, but this is good because you have AI perspective. I have more maybe conservative medtech perspective. And any final thought, anything you want to tell, like summarize that conversation?
I feel like I would like to only stress the argument about alignment, that it's thrown around a lot in terms of artificial intelligence. And again, healthcare case is no different. Aligning our goals as human goals, humanity goals, with the business incentives is the key point here, to actually use AI as an accelerator, as an accelerating force towards these technological advancements, and also in this way to improve the actual quality of life of many people.
And this is what we'll keep working on in Monterail, to help founders to build their products and also to have different opinions to help to make best decisions, right?
Iron sharpens iron.
Thank you.
Thank you so much.